Yeah, I think we are live now. Yeah, Veeraman sir, shall we start, sir?
We can start, no problem.
Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I am Balaji, TSM for Alchem Cardiac Aspiria Division. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on rosuvastatin, titled Galaxy of Experience with Rosuvastatin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. S.R. Veeramani sir, who will be our moderator for today's panel discussion. Welcome, Veeramani sir.
Welcome. Thank you. Thank you.
A short introduction about our chairperson moderator. Dr. Veeramani sir is a senior consultant interventional cardiologist and head of the Department of Cardiology at Madurai Medical College, Madurai. Once again, we welcome Veeramani sir. Welcome, sir. I take this opportunity to welcome all the eminent panelists who are given opportunity for this panel discussion. Let me take this opportunity to welcome the first panelist, Dr. Ganesan sir. Dr. Ganesan sir is a senior consultant interventional cardiologist and head of the Department of Cardiology at Meenakshi Mission Hospital and Research Center. Welcome, Ganesan sir. We have our next panelist, Dr. N.S. Prasad sir. Dr. N.S. Prasad sir is a senior consultant practicing at Trichy. Doctor is a managing director and cardiodiabetologist at IS Nursing Home, Trichy. Welcome, Prasad sir.
Thank you.
Let me take this opportunity to welcome the next panelist, Dr. Sundaram Marudhu sir. Dr. Sundaram Marudhu sir is a consultant cardiologist who is practicing at Dindigul. Doctor is currently associated at his own center at Saranamayappa Hospital, Dindigul. We welcome Dr. Sundaram Marudhu sir. Welcome, sir. With this short introduction, I will hand over the session to our moderator, Dr. Veeramani sir. Sir, you can set the context for the webinar. Over to you, sir.
Okay. Good evening, one and all. And it's a nice opportunity given by the Alchem Cardiology Division for presenting before you with the panelists of eminent panelists, Dr. Ganesan sir, Dr. Prasad sir, and Dr. Sundaram Marudhu sir, for the with the varied discussion points. They have given 5 discussion points on which whether the speakers or whether the panelists are going to talk about the content or we have to discuss.
So we can have a discussion mode.
Discussion.
Okay. In that case, first of all, first point they have given us a reduction of ASCVD risk with the statins and rosuvastatin, especially rosuvastatin. How the rosuvastatin is going to be useful in reducing the ASCVD risk. Over to the Dr. Prasad sir, you have anything to tell?
Yeah, yes, sir. Like definitely, we definitely the main aim of putting a patient on a statin therapy is to reduce the cardiovascular risk. That is one thing, atherosclerotic vascular disease risk. And moreover, if the patient is already an established patient of atherosclerotic vascular disease, definitely we need for secondary prevention also, we need to use statin therapy. As you are all aware, rosuvastatin is a statin which is a very potent statin in terms of bring down the numbers of LDL-C reduction. And we all know that once the patient has got an established atherosclerotic vascular disease, definitely we need to put the patient on either a moderate or a high intensity statin. When we mean a moderate intensity statin, we mean a reduction of less than 45%. When we mean a high intensity statin, we need a LDL reduction of at least less than 50% of the initial LDL readings. Or there are various guidelines say that established atherosclerotic vascular disease, our LDL-C should be 70, or for a very high risk individual it should be less than 55, and things and so forth. So definitely this is the the drug of choice, rosuvastatin moderate for all patients for whom we need to employ, especially in atherosclerotic vascular disease. We definitely need to use a moderate or high intensity statin, and that in that way rosuvastatin is a very good statin. I think with other panelists also they can give their views.
So Ganesan sir. So
yes, sir. Solunga, sir, please, sir.
Regarding the reduction of ASCVD risk with rosuvastatin, what's your comment regarding that? Is there any connection problem? In that case, Dr. Sundaram, can you tell some? Hello.
Sir, I'm. May sir,
you may talk. You will join.
Good evening, sir. Professor Veeramani, sir, Professor Ganesan, sir, and Prasanth, sir. Thank you for the pharma people for giving me the opportunity. Yeah, definitely. According to the atherosclerotic disease, statins are having main role, even in primary prevention and secondary prevention. Everyone knows the Jupiter trial. 10 years back itself, it proved the effect of atherosclerotic benefits with statins in primary prevention, even without any risk factors. In this case also, statins proved the role of their constant role of preventing atherosclerosis, cardiac events. Definitely they have a role. Especially nowadays, the aspirin role in primary prevention also reduced, but the statin role is very much proven. Even for primary prevention with less risk factor patients also, and older age patients. Even after around 70 years, if we start statins, they are definitely beneficial to reduce the cardiovascular mortality and morbidity. So there is definitely statins have the role. And especially rosuvastatin is one of the most potent statins as compared to other atorvastatin, rosuvastatin. The dose-dependent effectiveness is much more with rosuvastatin and atorvastatin. Most of our cardiologists, we are using atorvastatin and rosuvastatin for the secondary prevention most of the time in our country. This is my view. Thank you.
Okay. So, Ganesan sir.
Yeah, tell me, sir. Yes, sir.
Yes, sir. The reduction of ASCVD risk with statin, especially the rosuvastatin. What's your contents? Hello. Okay, the ASCVD risk is.
I'm not able to hear. Yeah, there's a lot of signal. I think. Hello.
Okay, sir.
Hello?
So, okay, sir. If you can tell anything in the meantime, you can start. Otherwise, we will discuss in the meantime. Hello.
Sir. Yeah. There is some issues, net connection issues with me for me.
சரிங்க சார், நாங்க இப்ப கண்டினியூ பண்றோம். நீங்க வந்து இடையில வேணா ஜாயின் பண்ணிக்கங்க. Hello. So the ASCVD risk is reduced with statins, especially rosuvastatin, as per the discussion with the Jupiter trial and other trials. We are continuing with the rosuvastatin And regarding the dosage and whether it is a high intensity statin or a medium intensity statin, we have to discuss. Sir, Dr. Prasad sir, which intensity statin, low, moderate, or high, for which type of patients you can prescribe?
Yes, sir. For whenever the patient has already got an established atherosclerotic vascular disease in the form of a cardiovascular disease or a stroke or a peripheral arterial disease or a chronic kidney disease, needless to say diabetes and the associated comorbidities, definitely we need to use a high intensity statin. When we mean rosuvastatin, high intensity statin dose, meaning rosuvastatin in the dose of 20 to 40 milligram. However, if the patient is just a high-risk patient for atherosclerotic vascular disease with diabetes, then we can definitely use a moderate intensity statin. And that when we mean the dosing of a moderate intensity statin, it is in the dose of 5 to 10 milligram.
Okay. Sundaram Maradu. Hello.
Yes, sir. I agree with Prasad sir. The same doses we are using also. Sir. In our practice in very acute coronary syndrome, we are using high doses for up to 3 to 6 months, and then we are switching to moderate dose. Usually, atorvastatin of 20 to 40 as a high dose intensity dose, and then we reduce to 10 to 20 of moderate dose. With atorvastatin, them are 80 is intensity, 40 to 80 is high intensity, and 20, 40 moderate dose we are in the follow-up we are using. Sir. Mostly in our practice in secondary prevention, these two statins are mostly used in our country mostly. Sir. I think so.
So, but whether you are monitoring something for giving the high intensity statin or a moderate intensity statin, whether you are during course of treatment, if you check anything to assess the problems with the drug.
Yes, sir. If the patient is having some associated liver disease like that or chronic alcoholic, we have to little bit reduce the dose and follow up with frequent liver enzymes monitoring and everything, sir. If the patient develops, most of the time in our practice, the myopathy and it is not that much common in our practice. Yeah.
Okay. Okay, thank you. And which statin combination for which type of patients? Evidence and experience with rosuvastatin. Sir, Dr. Prasad, sir.
Say like combination in the sense that generally we need to achieve the LDL-C goals. So we need to use the maximum dose of statin, or we need to achieve 50% of reduction in the LDL-C to achieve that. In case we are unable to use the maximum dose because of myalgia or any other side effect, we can use some other combination like ezetimibe or something like that, so that to reduce the side effect as well as to achieve the goals. That is one thing. So this is how we generally use for primary prevention. Of course, in secondary prevention, patient has got an established atherosclerotic vascular disease, then statins alone will not be sufficient. We need to use antiplatelet, either aspirin or clopidogrel or any other, so many now umpty number of agents are there, depending on whichever we want to use, we can use. Initially, as a cardiologist, you should be able to guide us better. In the sense, initially, whenever the event occurs for the first 1 year, generally dual antiplatelets are used. Then after 1 year, it is switched over to either aspirin or clopidogrel or whichever agent the patient is able to tolerate and things like that.
Sundaram, you can.
The same doses. Sometimes we are in high PGL levels, we have to come across to combine fenofibrate along with statin. At that time, we are not using very high dose of statin, not 40 or 80 of atorvastatin or 40 of rosuvastatin. At the time, we in the safer side, we can use around 20, 10 of rosuvastatin and 40, 20 of atorvastatin. If the PGLs are very high, to prevent the side effects and the intolerance most of the time. Wisdom is very good combination, Prof. So when the patients are not able to tolerate the higher doses of statin, if we use moderate to low dose of statin along with esgamate, it is very useful to obtain the targets of LDL and everything, sir. Other antiplatelets, usually there is no much side effects along with statin. So during high dose statin, then along with the PGL drugs we have to reduce the statin doses.
So the aggressive rosuvastatin treatment
Then there is
results in halting and regressing the progression of the atherosclerosis in the carotid and the coronary arteries respectively. This is one point. So we can give for a high dose and high intensity statin in the case of rosuvastatin maximum dose. And rosuvastatin reduces the oxidized LDL levels, an independent risk factor for cardiovascular disease in patients with hyperlipidemia. These are all the points we have to take into consideration when we give high intensity statin, especially in the rosuvastatin high dose. Similarly, high dose and low dose rosuvastatin treatments reduces the volume of the lipid rich necrotic core and contribute to plaque stabilization. These are all the things we have to consider in treating the patients with the hyperlipidemia to prevent and as well as to control the atherosclerosis. And the next point they want to discuss, every diabetic should be given statin after 40 years. Regardless the baseline LDL level, the evidence and the experience with rosuvastatin. Sir, Dr. Prasad, sir.
Yes, sir. As you are all aware, sir, diabetes, diabetes per se itself is considered as a high-risk individual for development of atherosclerotic vascular disease. And moreover, diabetes is associated with various comorbidities like hypertension, dyslipidemia, and other factors. So, irrespective of the LDL levels, because diabetes per se, they are all high-risk individuals, irrespective of the LDL-C level, definitely anybody above the age of 40 years have to be put on a statin. Of course, less than 40 years, if the patient is a high-risk individual, the patient has got high risk for atherosclerotic vascular disease, or in case the lipid levels, in case the LDL levels are more than 190 and things like that, or there is a family history of premature atherosclerotic vascular disease and things like that, or familial dyslipidemias and things like that, definitely less than 40 itself, it's an indication for usage. Whereas above 40, even if the LDL-C is within normal levels, there is no need to even check the LDL-C. Of course, we generally do it. No, we need to put the patient on a statin. At least we can put the patient on a moderate intensity statin. When you mean moderate intensity statin, either atorvastatin or a rosuvastatin alone can be used. So there is no place for low intensity statin as regards diabetics are concerned. So only if they are unable to tolerate, then we can consider other aspects. Otherwise, generally, the patient needs to be put on a moderate intensity statin, even if they don't have any complications or any established evidence of atherosclerotic vascular disease or chronic kidney disease. So all patients, irrespective of the LDL levels, has to be put. All patients above 40 has to be put on a statin, and this is one thing we need to tell all our patients, because what generally does, all of us with your wide experience, all of you are quite aware that once we check up and once the LDL level comes down, the patient asks, doctor, can you stop my cholesterol medicine? We need to tell them because of the neurotrophic effect, and in order to prevent primary prevention as well as prevent other complications, we need to take lifelong statins has to be continued. So this has to be stressed, and this is what patient education, this is what we educate all our diabetic patients, that you have to take statins lifelong, irrespective of their LDL cholesterol levels.
Very well said, sir. Very well said. The lifelong treatment with the rosuvastatin, that is an important point here. And Dr. Sundaramurthy, you have to add something.
Nothing, sir. Sir is beautifully told
Every diabetic
everything.
should be given statin, other after 40 years,
Yes, sir.
irrespective of their lipid levels.
LDL level. Yes,
Yeah,
sir.
yeah.
Atherosclerosis starts from the teenagers itself, sir, even in normal persons. So
Yeah.
definitely, diabetic patient, it is better to have a statin from early course. It will definitely benefit them, sir.
Yeah. We tell the students, whenever you diagnose a case of diabetes, already they are usually having a
They are
coronary artery. That's the
type 2
thing.
diabetes.
So in spite of their lipid level, the treatment with the rosuvastatin or in case of atorvastatin in after 40 years without any increase in level of lipid LDL, we can start. That is the thing to be considered, sir. Next thing, they want to discuss the statins for primary and secondary prevention, evidence and experience with the rosuvastatin. What the primary prevention, how it is acts, and secondary prevention, how it acts, can we discuss in a short time? Dr. Prasad, sir?
Yeah, as my previous speaker Sundaram Mardu sir has already said, we know from the Jupiter trial, rosuvastatin is the established, statin for primary prevention. So there is, apart from that, so many other umpty number of studies are there. So definitely for primary prevention, yes, the best option is rosuvastatin. It's a very potent statin, which is definitely will go a long way for primary prevention. Of course, for any secondary prevention, we have got both the choices. Either we can use a rosuvastatin or atorvastatin, depending on that. And we all know that apart, as Sir Veeramani sir has already said, apart from the LDLC reduction, it has got a lot of pleiotropic effects, in the sense that, plaque stabilization, reduction of the volume of the plaque, reduction in the carotid arterial media thickness, reduction in the so many other advantages, so that definitely it is a drug definitely to be used for all our all our cardiometabolic patients, rather patients with obesity, diabetes, hypertension, dyslipidemia, coronary artery disease, stroke, peripheral arterial disease, and so all cardiometabolic disease. These are the drugs which has to be used both for primary as well as secondary prevention.
Dr. Sundaram Mardu, can you add anything?
Nothing, sir. Usually in primary prevention, the dose is moderate dose we are using. In secondary prevention, usually we use the higher doses statins. Both rosuvastatin and atorvastatins are very well accepted in both primary and secondary. Other statins like pravastatin are available also. They are very well used in primary prevention. So atorvastatin and rosuvastatin in high dose usually used in secondary prevention, and the moderate to low dose used in primary prevention, depending on the presence of risk factor and the comorbidities patient is having. That is very. There is no question of any protein role.
Another one point is the rosuvastatin decreases the mean platelet volume, which is a determinant of platelet activation. So apart from the action of the rosuvastatin, the pleomorphic action, it decreases the mean platelet volume, and the rosuvastatin treatment reduces the arterial stiffness. These are all the additional points we have to consider when we are giving the rosuvastatin in a long-term treatment. Not only the acute coronary syndrome, in a long-term treatment, we have to consider these points. The lipid parameters, including the rosuvastatin, significantly reduce also the lipid parameters, total cholesterol, triglyceride, and LDL. Apart from LDL, triglycerides also can be reduced with the rosuvastatin dosage, especially in a moderate to high intensity statin dosage. And the low dose rosuvastatin would be more effective in improving the arterial stiffness in high risk proteins, high risk patients with dyslipidemia. The results suggest that improvement in arterial stiffness by rosuvastatin mainly depends on its strong lipid lowering effects. These are all the things they have given, and that is also to be acceptable. So apart from the LDL reduction, it also acts on the arterial stiffness and the mean platelet volume reduction, everything other that. So it has it shows more effect when apart from the anti cholesterol lowering effect. Is there anything to add, sir, Dr. Prasad, sir?
Nothing, sir, whatever.
Okay. Dr. Sundaramurthy,
Nothing, sir. No.
nothing more than that. Okay. Sir, Dr. Ganesan, sir, are you online? Sir is going to Chennai, I think.
Oh, sorry.
Okay, if there is anything to be, welcome people, you have to tell anything? Apart from the discussion points you have given, do you want to add anything? Hello?
Sir, there was only one query which came.
Yeah.
Triglyceride management, omega-3 fatty acid in triglyceride management.
So, Dr. Prasad, sir, do you want to tell anything?
So generally, there is a triglyceridemia. First therapy is we have to use the maximum intensity, a maximum dose of statin, and then see whether triglycerides are going to come down. Second thing is, in a diabetic patient whose blood glucose is not under good control, suppose we initiate the patient on insulin also, and the blood glucose is going to come down, then also we will be able to bring down the triglycerides to some extent, definitely. Then of course we have got the various options like using fenofibrates, using omega and all those things. So commonly we are able to achieve hypertriglyceridemia by using statins or fenofibrates in most cases, and controlling the blood glucose. If his patient is an alcoholic, reduction of alcohol and other things, all those things generally we are able to bring it down.
Okay. Hello, Dr. Sundaramurthy, to add anything regarding the triglyceride management with the omega-3 fatty acid?
It is an adjuvant therapy only, sir. There is no definite studies to establish the roles, but as adjuvant therapy with antioxidant property, most of the time it is cardioprotective omega-3 fatty acid benefits. We are using omega-3 fatty acids along with statins, but isolated role of omega-3 fatty acid is not established, sir. There is no role. As adjuvant therapy, we can use that one.
Okay. So that's all.
Yeah, thank you, sir. That was the only query, sir. Sir, you can give the conclusion to Mark, sir.
Okay. In conclusion, as per the company people and as per our discussion, rosuvastatin can be given in a high dose intensity statin, high dose in cases, especially in cases with the established hyperlipidemia and patients have diabetes more than 40 years. Even with the normal cholesterol level, we can give the rosuvastatin in a medium dosage. That will prevent the atherosclerosis and will prevent the development of the ASCVD. Risk is there. Apart from that, the arterial stiffness coming down and the mean platelet volume has come down, and the plaque stabilization with these effects. These are all the things we are considering in treating the patients of hypercholesterolemia, as well as the diabetic patients, as well as the coronary artery already established ASCVD risk patients, patients with the established ASCVD diseases, especially in the coronary artery disease, or stroke patients, or peripheral arterial disease patients, and diabetic patients. We can give the rosuvastatin in a dosage appropriate for that patient, and by which we can prevent as well as we can control the hyperlipidemia and the other diseases due to the atherosclerotic process. Thank you very much. Thank you for the nice.
Thank you.
Thank you for the opportunity.
Thank you.
Thank you, sir. Thank you.
Thank you.
Yeah, Kuleshekaran.
Yes, sir.
Yeah. You can give a vote of time.
Yes, sir. Good evening, sir. We thank this opportunity to Dr. Veeramani for moderating the entire panel discussion all the panelists for sharing galaxy of experience with rosuvastatin in clinical practice. Sir, we would also thank all the doctors who had joined us for panel discussion, and I am sure you will appreciate a galaxy of experience with rosuvastatin presented today. We salute all doctors and paramedical staffs who have contributed immense to keeping us all safe and healthy in these challenging times. We at Alchem Laboratories will continue to serve doctors and patients by making our brands of available, especially our chronic brands like Gluvilda, Jupiros, and Welcome. Thank you so much, sir. Thank you for participating with us. Thank you, sir. Thank you, sir. Yes.
Thanks for the opportunity.
Thank you, sir. Thank you. Yes.